Welcome. Today we are going to tackle a very important topic for your exams, infectious diarrhea. And we're going to make it super simple. Let's start.
So imagine a patient comes to you with acute diarrhea. What's the very first question you need to ask yourself to figure out what's going on? Is it a small bowel problem or a large bowel problem? See, our whole discussion today, it's all about building a solid framework so you can answer this question confidently every single time.
Okay, so here's our plan. We'll start with the first principles, then move to small bowel diarrhea and its pathogens. After that, we'll cover large bowel diarrhea and its bugs, and finally, we'll do a high-yield rapid review. Simple and logical.
All right, let's get started. Section 1. The first principles. So before we go anywhere else, we have to ask the most basic question, what exactly is acute diarrhea?
So here's the definition. And listen carefully, bachcho. This is a potential MCQ right here. Acute diarrhea is any diarrhea that lasts for less than 3 weeks. And the rule of thumb is you always consider it infectious unless you can prove otherwise. Got it? Less than 3 weeks, think infection.
Okay, let's draw this out in our minds, like a simple flowchart. Step 1 is always classification. How do we do that? By duration and severity. So if it's less than 3 weeks, we know it's acute. Now, is it benign and self-limiting, the kind that gets better on its own? Then you should be thinking viral. But if it's complicated, maybe there's high fever, severe pain, then your suspicion should shift towards a bacterial cause. It's a really simple first step to narrow down the culprits.
Now listen up. This is probably the most crucial differentiation in this entire topic. Put a star on this table in your notes, okay? It's all about small bowel versus large bowel. Look at the difference. Small bowel, think large volume, watery stools, not so frequent. But large bowel, totally different story. Small volume stools, but they're frequent, and they often have blood, mucus, or pus. Plus, you get that urgency and tenesmus, that horrible feeling of needing to go even when there's nothing left. If you can get this one table straight in your head, I'm telling you, you're halfway to solving any case.
So let's first focus on the small bowel type. The key word you need to remember here is watery. This is where the main problem is massive fluid loss. So we can break down the causes into 3 main groups. First, you have secretory diarrhea. This is where the bacteria produce the toxin inside the patient's body. Then there's preformed toxin diarrhea, which is your classic food poisoning. You eat a toxin that's already been made in the food. And finally, of course, we have our protozoal causes.
Chalo, now let's look at the main culprits one by one. Pay attention. These are your super high-yield organisms for the exam.
First up, we have Staph aureus. And the key thing, the absolute buzzword you must remember, is preformed, heat-stable toxin. What does this mean? It means even if you cook the food and kill the bacteria, the toxin is still there. It's stable, and it's just waiting to cause trouble. And because the toxin is preformed, think about it. The incubation period is going to be very short. It's direct cause and effect. The patient eats the bad food and boom, within 1 to 6 hours, they're sick. And what's the main feature? Vomiting. Staph aureus food poisoning is all about prominent vomiting. Now, another one that's very similar to staph is Bacillus cereus. This one is interesting because it has 2 types of toxins. There's a heat-stable one that acts just like staph, causing vomiting with a short incubation. And then there's a heat-labile one that takes a bit longer and causes diarrhea. And the source, fried rice, is a classic exam question. They love asking about Bacillus cereus and fried rice. Okay, now for a very important one, Vibrio cholera. This flowchart simplifies the whole pathway for you. The organism isn't invasive, it just sits there and releases its enterotoxin. This toxin then goes and activates adenyl cyclase, which shoots up the levels of CAMP. And what does high CAMP do? It opens the floodgates, causing massive watery diarrhea. This entire pathway is a favorite for exam questions, so know it well.
And the clinical result of this massive fluid loss, the classic rice watery stool, it looks just like the water you use to wash rice. Now, management is absolutely crucial here. The patient is losing liters and liters of fluid, so you must correct the severe dehydration with ringer lactate. This is not just about giving water, bacho. It's about correcting the dangerous electrolyte imbalances, especially the hypokalemic acidosis.
Okay, so we've covered the watery type. Now let's switch gears and talk about the large bowel. Here, the story is completely different. The organisms are typically invasive. The bug isn't just sitting there making toxins. No, it's actively attacking and invading the intestinal wall itself.
So here, these organisms invade the intestinal wall, and what does that cause? Inflammation. And that inflammation leads to the classic bloody mucoid stool. I want you to picture it like a battle, happening right there in the gut lining, causing all that damage and bleeding.
Let's dive into the main organisms responsible for this invasive bloody diarrhea. These are the cases that often present more severely in your clinics.
Simple. When you hear the word dysentery, the first organism that should pop into your head is Shigella. It is the textbook classic example of inflammatory bloody diarrhea.
Now, the pathogenesis here is a bit complex. It's like a double attack. The bacteria directly invade the cells, and they also produce toxins. It's a nasty bug. And a key extraintestinal thing to remember is reactive arthritis. Y'all know the mnemonic, right? Can't see, can't pee, can't climb a tree. That's Reiter's syndrome, a form of reactive arthritis. Very high yield point.
Next up is a very special case that you will definitely see in the hospital wards, C. difficile. This one typically shows up after a patient has been on antibiotics. Why? Because the antibiotics wipe out all the good, normal gut bacteria. And this bad guy, C. diff, sees an empty house and decides to move in and take over. The diagnosis for C. diff follows a very clear algorithm. You need to know this. As you can see here, we start by testing for two things: the organism's antigen, which is GDH, and its toxins, toxin A and B. Now, if both are positive, great, diagnosis confirmed. But what if there's a mismatch? Say the antigen is positive, but the toxin is negative. Then you need a tiebreaker. That's when you do a PCR test to be absolutely sure. This is a very practical must-know flowchart for your wards.
Okay, so to put everything together that we've learned, let's create a final master table. This is perfect for your last-minute revision before the exam. I suggest you take a screenshot of this one.
Look at this table. It connects each pathogen with where it acts and a high-yield buzzword. Staph aureus, rapid vomiting. B. serious, fried rice. Cholera, rice watery stool. Shigella, reactive arthritis. And look at Campylobacter, an important trigger for GBS, Guillain-Barré syndrome, that acute autoimmune paralysis. Don't forget that one. And of course, C. difficile, antibiotic-associated diarrhea, and you might see pseudomembranes on colonoscopy. If you just remember these connections, I promise you can solve so many MCQs.
And so I'll leave you with this final thought. A clinical question to test yourself. Apply everything we've learned today. A patient, antibiotics, then severe bloody diarrhea. What do you think is the answer? Think about C. difficile, its toxins, and what your very next step should be. Keep studying hard, and we'll see you in